Good evening, everyone, and welcome to the December 2023 NATS Chat. I'm Kari Ragan, the moderator, and I am so thrilled to, first of all, welcome Dr. Lesley Childs tonight. Thank you for being here.
Thank you. It's lovely to be here. It's a real honor.
I'm looking forward to this. I want to begin also by just thanking Inside View Press, which are the generous sponsors of our NATS chats. And please check out their book, Your Voice, an Inside View 3 by Scott McCoy. You can find it on Amazon or voxped.com. And as those of you who know my work at all, you know that I give Dr. McCoy a great deal of credit for my book. His book was instrumental in my teaching many, many years ago. So I hope you'll check out that book. So tonight we are going to talk all things vocal health with Dr. Childs. It's always such a joy and honor to have an MD on with us because it just helps us to get more clear on the information that we have as singers. And I think it's a really important. Before we jump into our hot topics though, I would love to talk beyond the bio. You are a singer by nature, by background, and that led to you becoming a laryngologist. So will you share a bit about your history with us?
Yes. Yes, singing led me directly into laryngology. When I was in high school, I remember my choral director, I had developed laryngitis, and it was a time when I was of course, wanting to be singing a lot. And my choral director said, I really think you should go. You should have someone look at your vocal folds, and I'm going to recommend this specific provider. And so I remember I went to his office and he did a laryngoscopy, and I remember I saw images from the laryngoscopy, and I looked at him and I said, I think this is what I want to do, like, forever. And he just smiled. At this point I was probably, I don't know, freshman or sophomore in high school. I mean, I was a baby.
Okay. Wow.
And by golly, it's kind of neat because I remember my senior year in high school, we had career day, and I went and I shadowed him for career day. And then eventually when I matched into my fellowship, my laryngology fellowship, I wrote him a letter. Just to let this provider know that he truly had inspired me, and that I was going to become a laryngologist after all. And his wife wrote me back. At that point, I think he was struggling with dementia, but I know it meant a lot to his wife, at least. So anyway, it's really, I really consider it a privilege to be able to care for singers. And I think it's helpful speaking the same language to some degree as many of my patients, just because I understand how kind of closely linked the singing voices, really the voice, but specifically the singing voices to our self-identity. I really think it's one of the most personal art forms on earth. So.
And you sing now? Do you have an outlet for your?
I do. I sing now. I continue to study voice and keep working at it. I need a lot of help.
Oh, I doubt that. I doubt. Do you find time to practice?
Not as much as I probably should. I think I might not be the straight A student that I should be, right? In that regard, at least.
No, there's no shoulds. I always tell, especially my avocational singers, right, that have busy careers, like there are no shoulds. It's not like we're in college, right, and we should be in the practice room 5-6 days a week working on our craft. That's just not the point at some point in our lives. So, and there's something I remember about you and Disney.
Oh, yes. This is when I get super embarrassed. Yes, that was another sort of crazy thing. I was in college. I was home for the summer, and a friend of mine called, and I don't know if it was in the newspaper. This is back in the days where the newspaper was the main form of communication, or what. But this friend said, "Hey, this was in Austin, actually, Austin, Texas. Hey, Disney's in town, and they're looking for Disney princess voices. You should go audition." And so, you know, I did, not expecting a thing, and I got really lucky. And so I did a little bit with them, intermittently from that summer between, I think it was my junior and senior year in college, actually through the beginning of residency, a few different recording sessions here and there. So I always say, like, maybe the occasional 3 or 4-year-old little girl has maybe heard something from that. But anyway, it was a lot of fun. It was a lot of fun.
I mean, you're a real singer. That's not just somebody playing at it. You were a professionally paid singer. That's with Disney. That's impressive. Yeah, that's really impressive. I love that. I should have also, in my introduction of you, Dr. Childs, mentioned that you are the director at the Clinical Center for Voice Care, the University of Texas Southwestern Medical Center. It's a mouthful, in Dallas.
It is.
Yeah.
Yes.
How long have you been there?
Gosh, going on 13 years now. And it's wonderful being back, you know, in Texas. I spent, you know, many years, many formative years growing up in Austin. So yes, I've been there ever since completing fellowship.
Okay.
It's wonderful. Yeah, it's a wonderful place.
Oh, that's wonderful. Now, you obviously, as a laryngologist, but you are a laryngologist who specializes in the performing voice. Because I find even in laryngology, as you and I talked about earlier this evening, it's still a relatively new field, 25-ish years that it's been around. That to me seems, I mean, I'm old enough to remember originally when I started working with injured voices, it was with an ENT, because they were old enough that they didn't have an opportunity to specialize, but they had kind of, we called them an ENT voice specialist back then. And then the field of laryngology has come along. But even in this city alone, we have probably 13 laryngologists. But I would say of that, certainly not all of them specialize in the performing voice. So it almost feels like it's a subspecialty within a subspecialty, the work that you do. Yeah. Okay. That's so. Go ahead, please.
Well, all I was going to say is I think you're right. You know, some, especially I think as our field has matured a bit over the years, we now have you know, 3 sort of subspecialties within the field. Professional voice would be one. Another would be more of a concentration in airway. And then finally, esophagology, or more of a swallowing focus. So absolutely, it is something that I've tried to make my main focus, professional voice.
And you have done quite a bit of research around singers with an injured voice. I was the beneficiary. Dr. Childs was the keynote at the conference that I run, Northwest Voice, the Art and Science of the Performing Voice conference, and gave an incredible presentation on some of the research that you've done and the findings. Would you like to give us some broad strokes about that research and what it showed?
Absolutely, absolutely. We felt like, as a voice center, I partner with 2 other laryngologists and 6 fabulous speech language pathologists, and we felt as though there were many unanswered questions. It was specifically with regard to singers, injured singers, and so we looked back. This was a few years ago, so we looked back about 9 years, and we kind of retrospectively analyzed a lot of data. Over 400 singers were included, and these were all injured singers. So injured singers are those with some sort of phonotraumatic growth on the vocal folds. And so we looked at those singers, and we were able to answer some really important questions. Our goal one of our goals was to be able to better counsel our singers. You know, when I see them in my office and I'm diagnosing an injury, questions arise such as, what's next? I mean, what are the chances I'm going to need surgery? I mean, is surgery even an option? Is this something that that I need to worry about? So that was one of the questions we were able to answer. And we found that about really the minority, about 1 in 3 of our injured singers actually end up requiring surgery. So it's a much lower number than I think probably many singers might sort of envision. You know, the reality is that 1/3 of our singers end up going to the operating room. The majority do really well with behavioral intervention alone. And so that, I think, was one of the main takeaways from the work that we did. We also were a little bit curious as to, you know, does specific singing genre sort of lend itself potentially to specific injury patterns? And so a really interesting finding was that our opera singers tended to present more with what we're going to call either pseudocysts or translucent polyps. You and I talked a little bit about semantics and nomenclature, but nonetheless, they're sort of like blisters. We'll call them blisters on the vocal folds. We have some theories as to why we saw that. We think that it's potentially that opera singers may notice very, very subtle vocal differences, potentially more readily than singers who sing in another genre, if that makes sense. In other words, the tolerance for any sort of vocal imperfection may be a little bit lower in our opera singer population. So that may be one reason why we ended up seeing more opera singers with these sort of blister type lesions. Also, we have a theory, and this is shared amongst other laryngologists in the field, that these blisters develop over a long period of time. They're sort of more chronic versus an acute injury. And so potentially, you know, the several hour performances and, you know, the sort of longer timeline in terms of the career span and those sorts of things, the long training ramp up, all of these things may factor in to this more chronic pattern of injury in our opera singers. Another really interesting finding, again, with regard to genre, and I could probably go on about this for another 4 hours, but was that nodules did not seem to at all sort of differentiate, meaning within all of the different genres, nodules were found with relative equal kind of equal dominance. What that means is maybe what this means, I should say, I have kind of postulated that maybe nodules aren't necessarily a singing related injury. Maybe they're more a speaking voice related injury, you know, just because there was really no difference in terms of nodules. Nodules were by far the most common sort of injury, but didn't really separate along genre lines.
That's an interesting hypothesis based on that data. That's really interesting. I've often thought that the nodules at speaking voice, we've talked about that for a long time. I feel like in the field that nodules generally are about the speaking voice more than the singing voice. I've heard that for a long time, and so interesting. But you're saying because you're not finding a particular population of singer that sings in a particular genre, that could support that.
That's right. That's right. So that's, you know, it's a possible, exactly, it could support that. I think that's a well said. I don't know that we have, you know, hard data to support that yet, but it's a theory. And you know, these findings were interesting. And again, we were looking at Actually, in the genre portion, we looked at over 700 singers, so quite a few folks. You know, another thing, just to completely switch, we looked at, because I think this will be really interesting to this audience, we found that when we compared professional singers versus not professional singers were more likely to undergo vocal fold surgery for their injury, and untrained professional singers were the most likely to undergo vocal fold surgery compared to trained amateur singers.
Interesting.
Yes. So, you know, potentially, again, there are some theories out there that may or may not be valid, but you know, potentially with regard to the injury type, maybe professional singers had more severe injuries compared to those who were not professional. Maybe also, you know, in terms of sort of their need for potentially a definitive and somewhat faster, quote, solution. I hate to even say solution, because a lot of times surgery is not the best solution for our singers, but maybe those were two factors. And then with regard to the sort of voice training versus not, you know, again, we'd like to think that the voice training lends itself to vocal proficiency, which then lends itself to, you know, maybe faster improvement with voice therapy and sort of rehabilitative behavioral intervention, things like that. These are all things that we really need to look at into sort of in more detail and in depth, but food for thought nonetheless.
Very interesting. Is there a particular direction you're going next with your research? You're busy
That's
writing.
a great question. Yes, right now I'm looking more at hormones, working on a chapter on that, on hormones and the influence of hormones on the female voice. But you know, I will tell you that I'm interested in actually looking at cis in a little bit more detail. Vocal fold cis. I have a hunch that maybe they're not so phonotraumatic. And would like to sort of look at that potentially, you know, in a prospective fashion, to get a sense of, you know, how are these folks using their voices compared to, you know, those with other sorts of injury. Anyway, that's something that I've been thinking about for a while, and just need to set that in motion.
That's interesting. I've always thought of vocal fold cis as, I don't think of them in the same way as the other phonotraumatic lesions, the polyps, the pseudocysts, the non, because I've always, I swear one of the MDs at some point said, you know, we kind of don't know where the cysts, just like women develop cysts in their breasts, right? That always resonated with me. So it sounds like you're going to go after some more specifics to prove perhaps that is the case, which would change treatment, which it would for sure change your treatment plan, would it not?
Yes. And you know, it's sort of lumped in the phonotraumatic literature. It's always sort of lumped in there, and I think it may skew our results a little bit in terms of voice handicap and even surgical outcome, right? All of these things are potentially, granted, cysts are not that common. Nonetheless, it's something that I'd like to look into more.
Yeah. Oh, I'll be really curious. So you started us down this little path, so I'm going to follow it. I have wanted to know for quite a long time, why do we have laryngologists, some identifying a phonotraumatic lesion as a pseudocyst and some as a polyp? And even within my clinic here that I affiliate with, we have a younger doc who calls it one, and a more mature doc that calls it another. So anyway, I've been wanting to ask this. It's probably a small audience number of members that would be interested in this answer, but for my own edification. I would
You
love
know,
to.
I love, and it's funny because that's when we start talking nomenclature, that's when you'll see various laryngologists kind of get really animated. Maybe that's the best word, animated. You know, I think it potentially is a regional thing. I think maybe it's also sort of a pedigree thing, you know, kind of where you're trained, you sort of inherit that language. But I will say, I think there's value to being, when we are discussing these and we're writing about them in the sort of scientific literature, if we can have pictures and very kind of detailed descriptions when we're referring to these injuries, that will help. Until we can all agree, which doesn't look like we're necessarily that close to doing so.
Okay.
We at least need to be really specific when we're writing about these lesion types and when we're presenting about these lesion types, so that we kind of can compare similar things.
But when I, as a team member, if there's a diagnosis of a pseudocyst, I can assume if somebody calls it a polyp, there's no difference. We don't have a differentiation between those two things. Is that correct?
Well, there are hemorrhagic polyps, and then there are
Right.
translucent polyps. So the
Right.
translucent polyps is more akin to the pseudocyst.
Yes. Okay.
And we believe, you know, that those are more of a chronic injury pattern. And that really does differ from a hemorrhagic polyp, because those we have observed that they are more of an acute injury. So they happen more suddenly. So unfortunately, there are two different types of polyps, and
Okay.
just to make
Okay.
it even more confusing.
Okay. Okay. But assuming, like you said, assuming it's a translucent polyp
Right.
/ pseudocyst, then we're
Yes.
essentially talking. Okay. Okay. That helps a lot,
Yes.
actually. Uh, and you know, as somebody who attends conferences, you know, the medical conferences for voice people, I definitely, over the years, it's fun to see those panel discussions where there's a lot of debate, where they'll put something on the screen and they will discuss diagnosis. We are not, like you said, we're not getting closer to common nomenclature across this country. Is that what I'm hearing you say? But as long as we use more specific descriptive language, we're generally talking about the same thing, even if it's identified with a different label.
Yes, I would agree. I think as long as we're very clear, whatever we're calling it, and we sort of define what that means, that's a good start.
Okay. Interesting, isn't it? You'd
Yes.
think that would have come farther, I guess. I would think that
I
would have come
know.
farther. No. We all have our bias in every field. We have
For
our bias.
sure.
Yeah,
For
that's
sure.
great. Let's talk COVID for a minute. There was a time where I just didn't want to talk about COVID anymore, but I feel like there's been enough of a gap. And I was just on a meeting earlier today where there was some conversation about that, and I thought, wow, I'd be curious from the medical perspective. What are you seeing any common results for singers to come out of COVID at this stage?
You know, the one thing that always pops to mind with my singers and my professional voice user patients is the impact of Zoom, you know, sort of virtual modalities for, you know, those who needed to kind of pivot and start working from home. And instead of in-person meetings, they started going to all of the, you know, computerized virtual ones. I think that, you know, some of the things that we've recognized is that, you know, modulation of volume and those sorts of things is a little bit harder to do when you're in a room, you know, all by yourself, sort of staring at a screen. And so, you know, recommending like AirPods or headsets, those sorts of things, hands-free, not holding your phone, those sorts of things has been, I think, helpful. So that's sort of one aspect of COVID. Of course, our COVID folks who are coughing, we will definitely still see folks who struggle with sort of even more of a chronic cough, sort of a long COVID, cough that can
Mm-hmm.
really impact the vocal folds. Masking. I have a feeling that, Kari, you probably experienced that, especially earlier on when we had the mask mandates. I mean, that really changes things for our
Yeah.
vocalists
Yes.
in a major way.
Mm-hmm.
Um, I'm trying to think of other sort
Are
of
there
voice.
diagnoses, I guess, coming out of it? Are there
Hmm.
diagnoses that are, I remember hearing early on with vaccination, there were cases where people were having temporary vocal paresis as a result
Hmm.
of the
Hmm.
COVID. I remember hearing that. If I heard it and you didn't, then I'm making that up. That is what
I
I
doubt
would
you're making
guess.
it up. I doubt you're making it up. I didn't hear that. I will say, I think for a while, and maybe this is still, I'm not certain if this is still sort of a standard treatment, but quite a few folks were being placed on steroid inhalers by mouth for their lungs. The lung is the primary target. Unfortunately, though, the larynx is sort of, an innocent bystander. And so the vocal folds end up with these steroid particles being deposited on them. And so that can be a real source of irritation,
Mhm,
and pretty significant voice change, sometimes even fungal overgrowth at the laryngeal level.
mhm.
So steroid inhalers are not always sort of benign when it comes to the voice, and so that is something that I at least have noticed a little bit
Mhm,
more now in the sort of post COVID era.
mhm. Well, it sounds like you're not seeing kind of some thematic implications on the larynx from COVID.
No, not directly, not directly. It's all been sort of indirect
Mhm,
uh, sequela.
mhm. Is it true, speaking of steroid inhalers, are there still concerns that that can cause bowing of the vocal folds long term with long term use?
I think we worry more about intralesional steroid injections. So when we're
Oh,
actually, depositing the steroid into right next to the muscle bulk, especially in a repeated fashion, that's where there have been some reports of thinning of that muscle or atrophy.
yeah.
Um, I don't know of any reports of atrophy related to the steroid inhaler itself, but for
Okay.
certain intralesional injections of steroid, which, we'll do that sometimes for scar, for intubation injury, those sorts of things. And so we have to be careful sort of the frequency with which we do that in a certain individual because of that atrophy risk.
Yeah. Yeah. Okay. I have a
Mhm.
client going through that right now, actually, and it is a couple
Okay.
of them actually. And there's discussion about how far apart. And one is for singers dystonia and the singer's dysphonia, and the other sulcus from a
Okay.
lesion surgery from a few years ago.
Sure.
So very different reasons that they're
Yeah.
both trying that. Yeah, it's interesting.
Mm.
All right, let's do easier ones for a moment. Let's talk about the common cold since it's that season. And boy, a lot of sickness right now, a lot of colds go and not a sweet little cold. It's taken people out, at least up here in the Pacific Northwest. So, what do you advise your clients when they come in? They're singers, they have a gig in a week, they have a pretty bad cold. What can they do?
Oh, so great question. And as you said, it's a common dilemma. You know, if I had a dollar for every singer who comes in and says, yes, I got laryngitis, I had a cold, but I pushed through and, my voice has never been the same since, right? I think the most important thing we can do as singers when we have a cold, when we're vocally under the weather, is to truly sort of shut it down. And what I mean by that is, if you can, rest your voice completely for even a few days. A few days is probably the very best thing you can do. I'm a huge fan of nebulized saline, humidifier use at night, you know, as much moisture as we can get. But, you know, the voice rest is probably the hardest thing for our singers to accomplish, especially, you know, holiday season. And my goodness, lots and lots of important, you know, important commitments vocally. But, you know, if we can at least rest our voices when we're not getting paid to use them, you know, at least, at the very least. And it's interesting, I think, especially my younger singers, I remind them, you know, when you speak, you're using your instrument. You know, I think a lot of singers, young singers, may not really remember that, you know, just not singing isn't the same thing as resting your voice, right? It's our vocal folds are vibrating hundreds of times per second, even when we talk.
Yeah.
So, you know, to the best of our ability, a brief period of strict voice rest is important. You know, if we're not debilitated enough that we still think we can potentially perform, well, then we really need to think about, you know, can you share the vocal responsibilities? Can we somehow, you know, make the repertoire so that it's a little bit less complex? You know, can we change the key of some of these pieces? You know, can we shorten the set? Can we, you know, for our folks who are in a band, can you do more backup vocals and, you know, those sorts of things? Mm-hmm. I think probably one of the most important things with regard to the idea of steroids, because I know steroids come up, oral steroids specifically in these scenarios, we really like for steroids to be an exam guided decision. And so what we mean by that is, we would really like to examine our singers, and that will help us sort of guide whether or not steroids are appropriate and for how long. Also, and again, steroids, I mean steroid pills, basically. Right. Typically also steroids, at least in my practice and my partner's practices, it's very much, we like to pair the steroids with the voice rest. Okay. We like to kind of combine those two, just because we know that steroids are a wonderful sort of masking agent, and that can be a little bit more dangerous if we're on the steroids, and, you know, a little bit of a false sense of security could result there.
What are speaking of steroids, because I know we always talk about you'll feel better, you'll feel like you're Superman or Superwoman, but, you know, be careful because you still have the inflammation or, you know, whatever is going on. What are the other concerns medically about steroids, that they're not just handed out willy-nilly?
Great question. Steroids are kind of fraught with side effects. I mean, for our diabetics, we really worry about the glucose level, the sugar level. It can absolutely increase glucose levels in our diabetics and our pre-diabetics. That can be a concern. Mm-hmm. Steroids also loosen the tone of our lower esophageal sphincter. So sort of the ring at the bottom of the esophagus sort of becomes a little bit more loose. That, in combination with the possibility for gastritis, which is irritation of the stomach lining, we can end up actually with some acid side effects. Mm-hmm. Increased acid exposure, potentially that's refluxing and causing changes at the laryngeal level. The most sort of horrific side effect from steroids is called avascular necrosis of the hip. It's very, very, very rare. Okay. But pretty catastrophic. It's basically your hip loses blood supply and you will likely be looking at some sort of major hip reconstruction. Again, it's it's very, very rare, but it is a possibility with oral steroids. So those are a few. Of course, I often will, talk with especially my female patients. I can say, it's like PMS on, PMS plus. There's a phenomenon called roid rage, where you're just a little extra punchy, a little short fuse, hungry. Your heart can race. Again, yes, very productive. Make your long to-do list, because you won't sleep a lot. You'll be revved up with the steroids and probably get a lot done. So yes, it's they're not completely benign. I think there are some theories that blood vessels are more leaky and that hemorrhage could be more likely, vocal fold hemorrhage, and I don't know that we have data to support that, but it is something that floats around a little bit. I think probably the risk of vocal fold hemorrhage is more related to sort of potentially that masking phenomenon, and so there are many reasons why we like to pair the steroids with the voice rest, but those are a couple of them at least.
It's interesting. I was on steroids for something else and went in for an eye check, and my eye pressure was really high. And I had happened, in the intake form, I happened to write that down. I normally don't, because those forms annoy me. And my eye doctor knows me very well, and he actually looked, because I never think they look at those things, and he looked and made that correlation. He said this could be the reason. And it was such a great example to me as a voice teacher to go, we don't, the MDs don't just hand these drugs out, or that there's so much that goes into the decisions that you make that I, as a voice teacher, would never understand. That's what you and I were talking about before the cameras were rolling tonight. We voice teachers get a little information. Oh, ask the doctor for steroids, as if it's nothing. But there are a whole lot of ramifications that you would understand from years of medical training that I would not. But so that brought that home to me, that he felt like it probably had impacted my eye pressure. And so then he made me come in, gosh, twice a week for quite a few weeks, just to keep an eye on it after that.
Wow, yeah. Even fungal overgrowth, you can end up with sort of a thrush of the larynx too, with steroids, especially if paired with antibiotics, so yeah.
Lots to consider. To consider. With it in that cold, you're bringing up the drugs, is that not being a benign drug? Mucinex, I think, is that a benign drug? The guafenicin, is it pretty? Are there any red flags or concerns about Mucinex?
I love Mucinex. The only thing that can be tricky is it comes in multiple varieties. So then there's guafenicin, right? Mucinex, and then there's Mucinex D, which is the decongestant variety. There's Mucinex DM, which is the cough suppressant variety. That's the 𝘱𝘓𝑚ethorphan. There are nasal sprays that are Mucinex, and so generally, I recommend to my patients that we stick with the plain Jane Mucinex. That we drink lots and lots of water, but I think it's a wonderful drug. It's been around for a while. It doesn't seem to interact with other medications or other medical conditions, but for sure the decongestant and the 𝘱𝘓𝑚ethorphan, so the D and the DM varieties, can be drying over time if used for sort of a chronic, long period of time.
I'm so glad you clarified, because I was thinking just the plain old regular that was first launched Mucinex. And it really, and as I understand it, it thins the mucus. It's not like the ones that the decongestants that dry us. It thins the mucus. So often, right? Yeah.
Yes. So, I talk about how we like mucus to be thin and watery, like good oil for a car engine. Actually, I borrowed that from one of our fabulous voice therapists. That was her analogy. But yes, it thins it so that it can better protect and lubricate the vocal folds. We don't want to get rid of mucus. We just want it to be thin.
Well, and so when clients are, if they're coughing from the cold, sometimes that can help thin some of that mucus that might be triggering the cough. Is that kind of okay thinking?
Absolutely. Absolutely. Yes. A mucolytic is really the sort of the class of drugs that guaifenesin sits in. And so yes, I think its primary purpose is to thin things so that they're more easily sort of ejected when we're sick. You know what I mean? Kind of gotten rid of from the lungs. But we use it and recommend it often for folks that are struggling with thick, gunky stuff. Primarily the water and the nebulized saline, those sorts of things are, I think, the best. But the guaifenesin, the Mucinex, can help.
Oh, I love that idea. Go for, because it's more natural to get out your nebulizer. Yeah. And I want to come back to that, but let's go to, because coughing, as we know, can be so dangerous or damaging or problematic for singers, whatever language we want to use. So what is it? I know there are ingredients that we want to avoid in cough suppressant drugs. Let's talk about that, because I think this is really critical.
Yes. So the diclofenac is probably the most common cough suppressant, DM. You know, anything that says DM, that's something that, especially if it's used for a few days, you know, under a week, fine, but not for weeks on end, simply because it can be really drying. Some of the codeine derivatives can mess with you in other ways, you know, in terms of constipation and sort of that mental fog. There can be even some dependency over time on the codeine derivative cough suppressant medications. And so that's where, you know, as much of the moisture and the Mucinex that we can get in, the better.
Okay. And are there like menthol and these type of products that can trigger
Yes.
reflux, correct?
Okay. Yeah. Well, in terms of, so for menthol specifically, we sort of hypothesize that it might be sort of an irritant to the laryngeal tissues, you know, over time, maybe even something that sort of desiccates or dries them, such that, you know, you put a menthol lozenge in your mouth and you have this like amazing numbing effect, but then like 10, 15 minutes later, it's like you feel like you need another one, you know, and your tissues feel sort of raw. And so we usually point people more towards the glycerin-based lozenges, or pectin is the name of the ingredient in the Breezers, like the Hall's Breezers products, and I'm sure you're familiar with the Grethers pastilles and those sorts of things. Glycerin seems to be a little bit more soothing. And what's important to remember about lozenges, just generally speaking, they do not touch the vocal folds at all. They will never, ever touch the vocal folds. Neither will the water that we drink. And so, you know, it's really these tissues in the mouth and the sort of the back of the throat, the pharyngeal region, that we're sort of soothing with these lozenges. But there's no direct effect on the sound source, on the vocal folds themselves. And then in terms of, I'm not certain about the connection between menthol and reflux. I think some peppermint is known. Peppermints can, yes, those can certainly trigger sort of a reflux sort of response. So I'm a huge fan with regard to reflux. I don't mean to sort of dive into that, but I don't know if we will. I don't know if alginates are something that's sort of a part of some of your singers' worlds, but we have really sort of latched onto those because they're natural and their mechanism of action is unique in that what alginates do is they more or less create a barrier, a physical barrier between the stomach and the esophagus. And so what's interesting is some folks, singers and non-singers alike, can have reflux of acidic contents and reflux of non-acidic contents. And so these alginates, which are over the counter, can prevent both from coming up to potentially irritate the laryngeal or pharyngeal regions. So it's a really nice option if we're trying to avoid sort of the proton pump inhibitor medications, the Nexium family, and even if we're trying to avoid the pepsid family, which are called H2 blockers or histamine blockers. So we're all pretty excited about these alginates.
I can tell because the last quite a few years now at conferences, you really see Gaviscon Advanced or Gaviscon Max. And now, then all of a sudden it became Reflux Gourmet. Now
Yes.
that's the hot one. Do you have a preference, or do you notice your clients have a preference, your patients have a preference?
You know, and there's another new one, by the way, Reflux Raft. So get ready.
I've not heard about it. Okay,
Yes.
RAFT?
Yes, Reflux Raft. I'm pretty sure that's what it's called.
Okay.
You know, I think with the Gaviscon Advance, I remember I used to encourage my patients to get the advanced variety. You got to get it from the UK, right? It had a higher sort of concentration of alginates. So I think the Reflux Gourmet and the Reflux Raft both are made here in the USA. And so, you know, potentially those are more accessible and maybe even better. I don't know. I know the Reflux Gourmet, they have a couple of different flavors and things like that. So
yeah. Have you tried them by chance?
I have. I haven't tried the Reflux Raft yet, but I have definitely used Reflux Gourmet a fair amount, actually. Yes, it helps me. It helps me.
Yeah, that's great. That's fun. You know, and speaking of reflux, you know, I remember it's a long time ago now, but there was a time where I was so frustrated because every client who went to the laryngologist was getting this reflux for the diagnosis, right? So at the multidisciplinary conferences, there was lots and lots and lots of conversations about this at one point where it's like, hey guys, are you overdiagnosing? And there was some really wonderful and interesting conversations. I feel like that has evolved quite a bit. Is that your experience? Evolved in the sense of docs aren't, at least in the laryngology, I still think GPs just without even examination give people PPIs and then don't monitor it, is my experience. But I feel like with the laryngologists, they seem to be starting with the alginates often. Is that because of the conversations that were had all those years ago, do you think?
I think so. You know, I think laryngology as a field, I think we are we have had those conversations. And so we're sort of tuned into the sort of debate. And I think when we get referred patients, whether it be from a general ENT or like you said, a GP, often our patients have already been prescribed and tried the reflux medication. And so often what we're doing is we're actually working to get folks off of these medications. And I think what we see as a field of laryngology is, you know, that hoarseness is just far too often, reflux is blamed basically as the source for hoarseness far too often. Now, what I don't want to do is discount the fact that reflux is a thing, and it specifically what's called LPR, which is another tongue twister, laryngopharyngeal reflux, is also a thing. And so there are folks who struggle, and the tissues in the larynx and the pharynx just are super sensitive to any sort of acid exposure, and it can really wreak havoc when that happens. But I just think we need to be careful that, and I think all of us feel the same way, that we're not kind of over medicating our patients. And a lot of times the proton pump inhibitors, unfortunately, they're quite finicky drugs. I mean, they cannot turn those acid pumps off. They can only prevent them from turning on. And so the timing of the medication is really crucial. We really need to be taking those medications 20 to 30 minutes before breakfast, coffee, tea. You know, if we've had a sip of coffee or a half a cup of tea, those acid pumps are on, and that drug's not going to do a thing. right? Because it
Interesting.
can't turn the pumps off. It can only prevent them from turning on. And so that, and
Hmm.
also what we know is for those who are prescribed proton pump inhibitors, it's a real disservice that the sort of over-the-counter varieties are sold in like 2-week packs, or
Yes.
2-week supplies, because our sort of data shows us that it actually takes more like a couple, 2-3 months of daily proton pump inhibitor use for the tissue healing to actually take place. So far too often we're either tweaking kind of how they're taking the drug, in terms of the timing and how long they take the medicine for, or ideally we're getting them off of the medication altogether because we're able to see on our exam that actually it's something else that's likely going on that's contributing to their voice change.
But it's diagnosed often by seeing redness, on the strobe.
And
There
that's
could
the
be
hard part.
allergies.
Yes, there are very few and potentially no kind of hard signs on laryngoscopy that say this is reflux. Really, the gold standard is to do what's called pH impedance testing, which is, placing a probe or some sort of, device in the esophagus to measure that. And so, yes, so that's an opportunity for me to sometimes educate my singer patients or any of my voice patients that yes, I know you were told this is reflux and you've been on a proton pump inhibitor now for 2 months taking it properly and you're no better. So I think that it probably wasn't reflux. You know what I mean? And so that's when we can say, let's wean you off of this medication and kind of think about a plan B sort of thing.
Which is
Because like I
very
said,
important. Sorry, I was going to
yes,
say the weaning off, if you've been on it for what, longer than 4 weeks, you would say, or
probably, yeah.
is really, and there is a protocol for weaning off when guided by a laryngologist for how to wean off.
Yes, because there can be, I think they call it rebound reflux, basically, if we sort of cold turkey off of these medicines. So alginates can actually be a really nice way to help with that process. And what's nice about the alginates too is they can be taken as needed. So, if you are keeping a food diary or you understand what it is that's triggering certain symptoms that maybe are reflux related, well, that would be a time to go ahead and take advantage of the alginate therapy at that point.
What frustrates me about the PPIs is that I see singers that are given them sometimes by a GP, not necessarily a laryngologist, but they're on them without being monitored for year after year, and they're young. And so that I wonder where the disconnect from monitoring them comes in. Somebody's refilling that prescription without having a conversation about, hey, I'm still on a PPI in year 2, year 3. Somebody's renewing that prescription. So, and again, that's not about the laryngologist always, but I find that
Sure.
interesting that it's prescribed, but then I don't feel like there's often the follow-up that I
Follow
would
up.
like. Mhm.
Absolutely. No, I agree. I think, the idea is 2 to 3 months. And then, if you're better, let's wean you off. You know what I mean? And if you're not better, let's wean you off. Either way, there's a pattern here. But you're right, especially in our female patients. And that's the other thing that I didn't mention. We're learning a little bit more about these proton pump inhibitors in terms of, we know that it sort of can mess with calcium absorption and vitamin D metabolism, right? So we, especially in our women who are sort of at the age where we'd be concerned about things like osteoporosis, osteopenia, those sorts of things, we need to be mindful. And then there's some animal studies out there too that are showing other sort of sequelae from these proton pump inhibitors, sort of after being on them for years and years and years. And so maybe those aren't as benign as we used to think they were.
Mhm, mhm. Well, let's turn for a moment to because this kind of relates to reflux. Um, Years ago, luckily, I heard things about digestive enzymes and probiotics, which can help. And so for my team, I oftentimes will pull in other members, for instance, a naturopath, right?
Mm,
Sometimes a physical therapist, sometimes a dentist, sometimes a cognitive therapist, right?
mm,
It's often multifaceted when we have a singer who has an injured voice. And as an example of this, I have a longtime client now diagnosed with MTD primary, not secondary, but primary MTD, muscle tension dystonia. And uh, and it was a complicated, like we were making strides for sure, but I could, he just kept reporting different facets. So I pulled a physical therapist in who specializes, got a lot of great information there. Finally, I got to the point where, because he kept just saying there was something off with the breath. And I thought,
mm,
well, I've done the works and the mechanics. You've had a physical therapist weigh in on what they're noticing in the mechanics. You've got a clean bill now from the laryngologist. Anyway, the naturopath tested him for SIBO, which is that, right, a bacterial, in the GI.
yes, like a
Yeah,
small
small,
intestine.
thank you. Yeah, and yeah, in fact, actually, I wrote it, small intestinal bacterial overgrowth.
Mhm.
And it impacts the diaphragm directly.
Mm. Ah,
And that, after a month on that medication, whatever this issue that he had continued to talk about along with the other reprogramming we'd done for
mm,
singing, that was the last piece. So I share that story because it just had such a profound, I've had those kinds of experiences many times with clients where we sometimes have to look outside the primary team to
mm.
find these little answers, the further answers. So I just wanted to know, as a person of science, how you feel about this Western and Eastern medicine approaches and philosophies. And do you ever recommend digestive enzymes or probiotics when people have
Mm.
reflux?
Well, first of all, before I'm going to answer your question, but I just want to, I was thinking about this as you were talking, and you are, Kari, such a champion for your clients, for your students. I mean, it is, I think it's kudos to you for not giving up and continuing to search for the answer. You know what I mean? I mean, um, we are so complex,
We
singers
are.
especially, right? And multiple levels and layers. And I just think your students and clients are absolutely so lucky to have you in their corner to
Yeah.
really, really champion them and not give up. Anyway, okay, yes. So as far as sort of specific enzymes and things like that, I'm not necessarily prescriptive in that regard. However, I'm a big believer in sort of diet and what we're taking in, and kind of a little bit more of a holistic approach. I think, you and I were talking a little bit about some Eastern medicine and Eastern traditions, and we maybe don't have the sort of conventional sort of data that we have in our Western medicine, paradigm. But boy, we've got history on our side when it comes to the Eastern traditions, and so the idea of acupuncture, or I'm trying to think of other sort of Eastern medicine things. This isn't necessarily, but mindfulness and all of those sorts of things too. All of that, I think, can be incredibly, incredibly helpful. I have some folks who just swear by sort of a low inflammation diet, right? And of course, there are low acid diets and cookbooks and things that can help guide folks. I think keeping a food diary, keeping sort of a symptom diary. I encourage my patients, like, let's really work on becoming aware of what might be affecting X, Y, or Z, from literally the food and drink you put in your mouth, what time of day, is there caffeine, is there not, right? All of these things, the medications and supplements that we're taking, right? All of them play a role, and can certainly impact our vocal health in ways that we wouldn't suspect. And I'm not surprised that physical therapist was helpful, because we are mechanical beings. I'm reminded of that, when I have a hip issue and I'm told it has to do with like my contralateral obliques, and you know what I mean? Things that I wouldn't have ever thought about. It's really humbling, The body is complicated, very complicated.
But it sounds like you're open to other means of helping our clients, if it, like an acupuncture or like supplements, if they feel like it's useful.
For sure. We partner with, so we're big believers also in cognitive behavioral therapy. We partner with a psychologist who has been really, really helpful with a lot of our singer patients. And we also have a physical therapist who really specializes in sort of jaw, neck, shoulder, myofascial release approaches. And so, yes, it takes a village. It takes a village.
Yeah, I have a therapist who works with a lot of my, especially singers with injured voices, who specializes in the performing voice because she was a singer. She was an opera singer. And so it really understands the special needs of, as you said early on, to bring the chat full circle about how we self-identify with our voice. It's critical to our humanity. It's all tied in. So, well, Dr. Childs, I cannot thank you. I mean, this was a wealth of knowledge. I know that our listeners are deeply grateful to sit and get to pick your brain on all of these things is just extraordinary. So thank you so much. I know this will be useful to a lot of people for a very long time.
Thank you so much for the opportunity. It's a pleasure and a huge honor. Thank you.
Thank you. And everyone, the next NATS chat will be January 14th. Speaking of mindfulness, the topic is the mindfulness of singing, bringing ancient practices together for a breakthrough experience with Denise Bernardini and Tony Crowder. So I hope you'll join us January 14th. In the meantime, I hope you all have a wonderful holiday season, and we will see you in the new year. Good night, everyone.